Welcome to Pemba On Demand. I'm Norm Chapin, your host. I am very excited to welcome you to our podcast. Pemba On Demand is produced for physicians interested in professional development. We will be discussing a wide range of topics on the podcast. I will be interviewing physician leaders from the U.S. and from other countries who have graduated from the Physician Executive MBA program at the University of Tennessee. These physicians will be sharing stories of professional and personal growth, overcoming challenges in their organizations, and discussing key leadership skills they have learned from the MBA program and ongoing professional development. Officer at Northwell Health. Northwell Health is the largest healthcare provider in the state of New York. Prior to joining Northwell Health in 2017, he served as the president and CEO of New York City Health and Hospitals, a provider of acute, post-acute, and outpatient services, as well as providing insurance products in the New York market. He was appointed to that role by then Mayor Bill de Blasio. He has also served as the former CEO of Cook County Health in Chicago between 2011 and 2014. Throughout his career, he has focused on population health issues, equity in healthcare, and the impact of the social determinants of health on our patients. He began his career in Brooklyn at the Lutheran Medical Center. He is also a Pemba alumnus from the class of 2000 and has his CPE from AAPL. He has served on many local, regional, and national organizations and is really a nationally recognized physician leader. Tonight, I'm pleased to have Dr. Raju joining me. Ram is going to talk with us about quality in healthcare tonight. Ram, welcome very much to the podcast.
Oh, thank you. Glad to be here.
Well, it's a pleasure to have you here. I am excited to share your topic tonight. I know you and I have participated in several meetings where we talked about quality in healthcare, and I thought it would be great to have you on the podcast.
Oh, great. Thank you. Glad to be here.
So maybe we could start a little bit and talk about, you've had a long career in healthcare. You graduated from the Physician Executive MBA class at the University of Tennessee back in 2000, and you've held many leadership positions in healthcare. But I'd be interested if you could just take a few minutes to share with us what you think the current state of quality is in healthcare and what you think some of our top priorities are in healthcare as far as quality and safety.
So, I think when we started with quality in early 2000, maybe late 1990s, quality was really a differentiating tool, marketing tool. People touted their quality of care, and then based on that, they were trying to get more of market share. But in the last 20 years, the quality has become a commodity. It becomes more a commodity. It's not really a distinguishing feature because most of the organizations have really gone a long journey in quality. And overall, the quality of care in this country, both quality and safety, has improved precipitously, tremendously. So the concept of able to market an organization based on quality or safety, marketing on what we call as a cost effectiveness, how effective it is, cost effectiveness, efficiency of care, and most importantly, I think the performance of the healthcare delivery system. Is it easy to access? What is your overall satisfaction with it, right? And also, most importantly, I think the future will be more on convenience rather than based on safety and quality. Don't misunderstand me. I think quality and safety are very important. It continue to be a factor. But people are going to say, is healthcare convenient to me? Can I get my doctor at the time I want it? It is available to me, and how long I have to wait, and what are things I need to get it done. So those kind of differentiating factor more than quality and safety, because I think mostly healthcare organizations have done that well.
So it sounds like you're really talking about sort of a transition or a modification of the definition of quality to be more than just did the procedure go well, you're talking about access, you're talking about how the patient or the patient's family potentially experiences the organization, it sounds like.
Yeah, absolutely. Quality is not just on care alone. It's the other factors which come into picture makes a difference. And if you move on to of care, we all know that the quality of what we deliver in healthcare only controls 20% of the outcomes in chronic diseases in this country, and 80% depends on other issues. So we also have to learn to move away from treating a disease than treating a person. So we are very, very good in treating diseases, and we have done that a good job. But we need to make that pivot to go and treat the persons, because the disease does not exist in a vacuum. A disease exists in a person. So the outcome of the disease in that person depends purely not on the quality of care we deliver. It also depends on the socioeconomic condition in which they live. The case in point is that you could treat the best diabetic doctor in the whole world, but if the person lives in a food insecure area, not able to adequately manage his food needs and able to follow your dietary advice, then that expertise is not going to produce the results you expect to produce. So I think we have to move more and more into a holistic medicine of treating patients and their circumstances, their surroundings, and their social issues, as well as we do with their disease process.
So how do individual physicians respond to this challenge? I mean, this is an amazing challenge in terms of physicians not just focusing on an individual patient's disease, but thinking about all of those social determinants that you referred to. But how do we respond to that new challenge?
It has happened three different ways. One has got to be, of course, utilization of data. The physicians and the hospital system should use the Z code in the ICD-10, which basically captures the social data of the person, and that should be captured so that you get a insight into the patient's social issues, which comes with that. Because zip code matters. In fact, I would argue the zip code matters sometimes more than the genetic code of the person. How long you live and how well you live depends on where you live. And the zip code makes a difference. That's the first thing. The second thing will be the government has got to start reimbursing doctors not only based on the CMI, the case mix index, and also based on the social risk of the person. Because if a patient is socially at risk, the doctor spends more time with them, and there are more challenges to encounter. So that has to be taken into consideration. And the last but not the least is that doctors need to understand that we have to understand the patient much better. When we kind of tell them to follow certain things, eat this food, they may not have enough money to eat that, buy the food, because cheap food is still, fast food. It's cheaper. Healthy food is expensive. Or we tell them, you need to take a nice walk every day, but they live in an apartment complex which is like 5 stories and there's no elevator system, so they cannot really walk up and down and go for a walk in the apartment. Or they live in a neighborhood which is not unsafe for them to do that. Or they don't have support systems to take them out and do those things. They have an social isolation, which basically creates a bigger issue. So the physician need to understand the various confounding factors which come into picture to do that. That simply means it's not going to happen overnight. We need to start teaching medical students from a time saying that please do not treat the disease of the patient. Understanding the patient gives you much better outcomes than just understand the disease. So we have done a good job understanding disease much better, and we have done a great job. That's why we have the greatest rescue care system in the world. But we do not have a real health care, not talking about sick care system. The real health care system is not there. So we have to figure this out how to do that. So 3 things: government, reimbursement, data collection, and the mindset of the physicians all need to come into picture.
So, as you know, there's a lot of quality metrics that healthcare organizations and physicians are being held accountable for by payers, by the government itself, by various accreditation agencies and those types of things. What how would you see those change in order to help us achieve the type of quality and improved outcomes that we need to see in this country?
Okay. I think the first thing we need to happen is, as it's happening right now, is we are becoming more and more outcome measures as opposed to process measures. So the quality, as we first envisioned, is all about quality measures, about process measures. Now we are becoming more and more of outcome measures. Then the outcome is also, we are measuring outcome of disease, but not necessarily outcome of the patient. So that has to be taken into consideration, right? For example, your diabetes may be under control, but the patient dies of other reasons, then the patient dead anyway. So it doesn't matter how well you control your diabetes. So the outcome measures has got to move away from disease-based outcome measures into patient-based outcome measures in overall income. So to do that, you need to really look at the entire. So the future will depend on, especially the cost escalation which happens in our country. The future will demand that people produce outcomes for the patients, not outcome for the disease, which is a little different from outcome for the patient. And of course, the process measure need to be retired. It doesn't matter you give beta blocker to the patient with heart attack, or you gave them aspirin, as a patient with angina. I don't think no one really worries about it, because that is not a very effective way of measuring the quality of care given to a patient. Just because you gave something, it doesn't mean that benefited the patient or the patient took it. So I think that is where it's going to change. I think the government is going to change that, and as well as we're going to change. The companies are going to change that, because they are more interested in making sure the patients are well and not necessarily control the diabetes better. So they control diabetes better, but the patient has got renal failure. Then that doesn't really make a big difference for them. So that's one thing which is going to happen. And with this escalating, cry for equity in medicine, which is becoming more and more a buzzword in healthcare, the government is probably also going to look at slice and dice the data based on not purely diabetic patients, also various ethnic groups of diabetes, how well the diabetes program worked well for blacks in your population or in your patient population. How will it work for Hispanic population? How will it work for people in a rural areas as opposed to people in the geographic areas? So all those things are going to play a big role in the thing, because there's a huge discrepancy in the outcomes, right? The rural population has got classically poorer outcomes compared to the people who got access to healthcare, and the people with the insurance do much better, and the people with public insurance tend to do worse in the outcomes compared to the people with private insurance. People who've got a higher education tend to do well with outcomes than the people who don't have the education component. Language barrier is a big issue. We continue to have a problem. And of course, the last but not the least is the older people. The people who are, older people tend to have much poorer quality of care, which we saw, in spite of the fact that, COVID took a lot of older people, by a predominantly very high number of mortality. Not all of them could be attributed to the old age alone. A lot of them has got to be attributed also to the access to healthcare and the quality of healthcare which is delivered in the nursing homes in our country. It is far less desired than what is being done in some of the high-class hospitals. There is a huge discrepancy. If you come to the hospital, you get a great care, and then you go to nursing home, the care kind of drops way down, because we don't have enough personnel in the nursing homes to take care of you the way you need to be taken care of. So there is a huge disparities in healthcare, and equity is not based on racial, ethnic, region. Definitely it's a big issue. It's also based on economic factors, educational factors, rural versus, and urban, as well as old age versus young age, as well as languages. So all these things are going to play a more and more vital role. If you want to deliver so-called quality of care, then we need to take into consideration all those things. We just cannot be focused purely on one disease and one measurement.
So what are Our healthcare system is very complex, as you know, and I agree with you. I think our healthcare system here in the U.S., it's where people go for rescue care, right? If they have an oncology issue or they have a serious health issue, I mean, I don't think our healthcare system is paralleled anywhere in the world. But what is it that needs to change about the structure of our healthcare system in order to align the incentives properly to achieve better population health and to be able to allow physicians to really get engaged in addressing social determinants of health or health inequities in their communities?
No, the healthcare system is designed for a different century. You know, we need to redesign the healthcare delivery system a different way. Healthcare delivery system designed for the early part of 20th century, we still carry on the same thing, which has got to be very different. That was basically designed as a disease management. They basically felt at the time, if you manage a disease and you do well, so we did a good job managing diseases much, much better over a period of time. That's why we excel in rescue medicine. We are very, very good at it. But the focus has got to change, not just managing disease, keeping population healthy. That concept was a very different concept. So that concept was basically given for many years to very peripherally to public health departments. That their job to give the vaccination, immunization, keep them all happy, and catch rats and use mosquito termites, whatever you do, just make sure it's all right. But that has changed. That has changed a lot, right? COVID has shown how a public health can really tax a system so badly. It is how much it is intertwined, public health and the healthcare. 15 years ago, we never cared. Public health is here, healthcare is there, and a very small portion of our hospital systems really work closely with the public healthcare system. Unless there are one major example, difference is Cook County, where I manage the healthcare delivery system, as well as I'm in charge of public health of Cook County. So there are very, very few municipalities, counties in the country which kind of combine that. But big rude awakening during COVID, it says, if you don't manage your public health well, your healthcare delivery system is going to be, completely catastrophically affected. So we need to change that. So that's what is going to happen over a period of time, that people need to understand that the disease focus has got to change into health focus. And that's what is going to see in the future as it happens. That's what they have to do. And that simply means we have to train our incoming doctors in such a way so that they're just not keepers of management disease, are also keepers of good health.
I think that's a great insight, and it's a very difficult problem, but I know that you've been very involved in public policy. You've been involved with several administrations advocating for changes in the healthcare system. Are you still involved in public policy? And maybe you could talk to us a little bit about the types of things that you're engaged in right now.
Yeah, I still teach a very popular course of, it's Roosevelt School of Public Policy in New York City, which is one of the very famous public policy institutes. It actually happens to be in the old house of FDR. FDR's old New York. He donated to the CUNY system, and that's where the Public Policy Institute is there. So I teach there. Every Wednesday I go there, I see the big picture of FDR, trying to get out of the car. So it's a kind of a historic place. So the course is about policy and politics of acquiring equity in the United States, because it's nothing to do with equity. The health care in the United States is policy oriented. The government, to a great extent, controls the healthcare delivery system in this country. They decide who to pay, who is eligible for payment, how to pay, how much of money to pay, what are all the measurements you will be measured on. They license you, they license your organization. Every instrument you buy has got to be approved by FDA. Every medication you administer has got to be approved by somebody. So this is a tightly controlled government system. So the policy is absolutely important. I don't think the doctors, to a great extent, don't understand how much the health policy really intertwined in their lives and their practice of medicine and what happens with that. So that's the first thing they need to understand. And of course, health policy is absolutely tied to politics. There is no altruistic healthcare policy in this country for many, many, many years. Every policy is controlled by ideological basis of what need to be done. So that is the issue. We have to understand that. So the health policy going forward, we are in the process of every government looking at it. Okay, we have to control the healthcare cost. We have to maintain the quality. At the same time, we have to make the healthcare more equitable across the country. Right. The people do it very differently. The people of liberal persuasion, they think that healthcare need to be more equitable because it is our moral responsibility and social obligation to keep people healthy. From a conservative philosophy saying that it is better to have a healthy population because the healthy population is the most productive population for economic development. So whichever way you look at it, people agree that the population need to be kept healthy because whatever reasons you want to keep them healthy for, right? So that is where the commonality of the ideological ends. Then the question is how to get it done. That is where the big fight goes on. Whether we should fund it or they should earn it. Is healthcare is a privilege or is it a right? So these discussions keep going on for a long period of time, and they continue to happen over a period of time. But everybody agrees to a great extent, whether we get a universal healthcare in this country or not, everybody agrees that there must be some form of, accountability in healthcare to the persons, as well as they need to understand both are accountable. And what percentage each is accountable is something which is still being debated. So the future healthcare policy is about, cost containment to a great extent, keeping population healthy, and keeping the healthcare funded the right way as a part of it. And how do we manage this large number of older generation, especially baby boomers like me who are retiring and then they happen to be living for a longer period of time, and also people who are living with the chronic diseases much more effectively managed compared to 30 years ago. So people are really managed. The people who just died of chronic illnesses are living longer and longer because we have a much better way of managing them. So all those things puts a huge problem on the demand side. And then there is a huge problem on the supplier side because we do not have enough healthcare providers to provide services for this aging population, especially with the large amount of chronic disease management needs as we go into that. So that is where we need to manage. So it's more of not a healthcare issue, it's also an economic issue in this country. I think we need to understand that because the American economy and the healthcare is intricately intertwined. You can't separate one from another because we are spending close to 18% of the GDP on healthcare. So anybody is going to say, wait a minute, if somebody says it's not an economic problem, this is really a medical problem, I think that they're not right because this is really an economic problem going forward in a way to do that.
One of the things that you mentioned was the nationalized or socialized healthcare system. Do you think that with the amount of government involvement that you were talking about and that we've seen, especially since Medicare came onto the scene, it certainly has increased over the last several decades, and it's become a fact of life in healthcare, and it's, as you say, it's intertwined in terms of how we provide healthcare now. But I'd be interested to know your opinion as to whether or not we can achieve the outcomes that we would like to achieve with the commercial versus governmental payer dichotomy that we have in this country.
No, I think when I mean universal healthcare, I do not mean universal healthcare provided by the government. There are countries which have got universal healthcare which is not necessarily provided by the government. Right? There are universal healthcare because we basically had a very strong employer-based healthcare for many, many decades. That has dwindled. It dwindled over a period of time. The benefits are cut and over a period of time, the privilege of health insurance, a part of the job, is kind of going down. There are not many people are doing that. The health savings accounts are coming into picture. People are managing their own way. People can choose their own insurance. And the ACA basically gave them an opportunity for the employers to say, hey, I'm not providing care. You can go and get your own care through the ACA. So all those things are really kind of change the way we did that. So I do not want to first categorize universal health care does not mean universal health care provided by the government. But the question would be, we as a country should expect every one of us to have healthcare insurance. We know that every one of us who drive a car should have a car insurance. Right? We kind of take that for granted. Why do we not insist on everybody who has to have an healthcare insurance of some sort? Right? For the people who can't afford it, we need to figure out how to make it affordable, right? The way we want to do that. And of course, that must be something. Otherwise, everybody suffers. What happens here is that then the problem is when they don't have insurance, that does not mean they don't get care. That simply means that they get care for which they are not compensated for. People are not getting compensated for. So care is the same, whether you are providing through the insurance or not providing the insurance. The amount of care consumed is going to be exactly the same. I can argue with the healthcare economics, which I have studied this for over 20 years, is actually the cost is much higher. For the people who really seek care in the emergency department, it is much more non-insured patients who continue to get primary care in the emergency department is more expensive to the taxpayers as well as to the providers who provide this care, as opposed to doing that. So it is the best interest of people for that everybody should have insurance of some sort, because we all shown that people in insurance are very judicious in using their care, especially people who got insurance, the co-pays. They really manage their care much, much better, and they are much more careful in getting how do you want to get their care and where do you want to get the care. The quality of care is definitely much better. And this kind of a huge amount of debt which they undergo both at the patient side as well as the providers who provide this care for uncompensated care is also a big issue for them. So I think we have to understand that everybody having insurance is a good thing over a period of time, not necessarily provided by the government, but there must be a mechanism for people to have that. And I don't think that is really wrong. Why are we not? How do we have people drive a car with the insurance, or you have a home, you get insurance. You travel by plane, you get insurance. This is like an insurance mayhem is here in this country. We believe in that. Any procedure which has got a risk involved, and the risk will be enormous amount of money will be spent on, then we tend to insure them.
Yes.
So I don't know why we don't insure these people. So I think this insurance debate has got caught in the ideological basis because people believe that the universal insurance means socialized medicine. No, it is an individual responsibility that you need to have something so that your care will not be transferred to me.
I think that's a great distinction because you're right. In my mind, I've always thought that universal health care or insuring everyone would default back to a governmental program and would become sort of like a socialized healthcare. But it's a good reminder for me that there are other options besides that include private and public collaborations to make sure that we have a population of people who have adequate insurance. Going without medical insurance right now, I'm continually hearing horror stories about people who are driven into bankruptcy because they don't have insurance and they have health care needs that they just can't afford. I read somewhere a few months ago that it's the leading cause of bankruptcy in the United States now.
Yeah, absolutely. You're right. Because the problem is the productivity of the people gone down tremendously because we are a nation which depend as we have a nation which is getting older and older. So we need younger people because those are the people who are going to be the productive citizens who are going to keep the economy going. So we need to have a productive, healthy population to get that done. And if that requires people to remain healthy, and then insurance plays a big role in healthcare access, definitely it does, and the quality of healthcare they receive, then I think it is kind of extremely intuitive to say, hey, wait a minute. If I want to keep you, if I can give you $20 worth of healthcare and I can keep you so that I can get $80 worth of productivity out of you, right? So I think that's economically sound model. Whether even if you're not a liberal thing, you still believe, hey, I want to have an economically productive, healthy population. So that's the only way I might keep my economy growing. Otherwise, my economy will not grow on just a lot of older people.
Great. Well, thank you for that insight. This podcast is sponsored by the Physician Executive MBA program at the University of Tennessee, Knoxville's Haslam College of Business. In less than 1 calendar year, this program will equip you with valuable business acumen and leadership development not found in traditional medical school curriculum. Are you ready to join the longest-running physician-only MBA program in the country and a network of nearly 1,000 Pemba graduates? Visit tiny.utk.edu/POD podcast for information about this exciting opportunity. And now we'll return to the episode. I'd like it if you could share with us a little bit about how you became so involved and so knowledgeable in public policy, healthcare policy. What was it that sort of led to your transition from a clinician into a physician who engaged in these types of topics?
The process was kind of little gradual because I came to Pemba because I'm a surgeon for many years and my hospital was going through a huge managed care, what they call tsunami, which was sweeping across the United States in 90s. Every hospital trying to, the managed care was very new at the time. And the hospitals were trying to, merge themselves, join themselves to have better market leverage to get a better managed care contracts. Physicians are forming IPAs and groups and all those things, which are all new. So my hospital was going through the same thing, and being in a poorer neighborhood and also a teaching hospital, but didn't have much of a big deep pockets. They really was exploring how can we keep the hospital, stay economically viable. So the idea came out that we need to start a trauma center, and because everybody say trauma center loses money, but we looked at it that the location of my hospital, most of our trauma will not be what we call as a guns and knife club. About penetrating trauma, most of them will be motor vehicle accidents, which usually pays well because they eventually have no fault insurance which comes in, or somebody's insured, or if they're not insured, they're always a lawsuit, and then you actually get the money, whatever they are awarded. Part of the money comes back to the hospital for their care, because they are indebted to you. So we cannot do that. So I came to Pemba because to understand the economic model. How do we create a trauma center and how many admissions you need? What should be the money I should get? So that's what I came into the thing. So followed by that, I went into trauma and then more and more got administrative involved. As I got administrative involved, I understood how much the government plays a role in the healthcare. They have a bigger say in healthcare than anybody than I ever realized, because like most of the doctors, I thought that I'm the king of the castle. I decide what I should do to my patient, what patient know. I write the prescription. I have the power. I decide who to see, when to see. No, that's absolutely not right. I knew that's not true. I said what I can do and what medication I can prescribe depend on the HMO tells you that is in the formulary or not. The patient comes back to me and says, "Doc, this prescription not covered. Can you write me another prescription?" They say no. The hospital say no. DRG 3.5 days. Discharge a patient today because you are really your patient overstaying. Get him out of here. Or the company says I can't approve MRI because your MRI is not approved because it's not indicated. So your practice was so much curtailed by so many things a part of it, right? So when I understood that how much the government controls it, then I got interested in how does the government control healthcare? Through policy, through reimbursement, through mechanisms, regulatory mechanisms, approvals, certificate of need. And when you want to do that, I want to go to a trauma center. I got to go before the government and say there is a need for the trauma center in my locality. I got to prove. So everything I do you realize that when you're administrator, not when you're a practicing doctor, because you're just in a small fish tank. You're just basically trying to manage your thing, and you think that's a Pacific Ocean. Whereas that's just your fish tank, and there you are the king. So when I understood that policy, I got interested in policy. Then I started, involved in the healthcare policy almost in every presidential campaign for the last 20 years. I was involved in shaping policies, and the culmination came when we were all, a few of us were involved in crafting ACA. In 2009 and 10 to get that done. So I always got involved in policy. The policy does with the politics, the social obligation, the prevailing trend of the voters, as well as the economy. All these things come together. And the practice of medicine. So this is a unique combination. I enjoyed it because it's like, I was able to look at the policy from a doctor's angle, from an economic perspective. I looked at it from the social perspective. I looked at it from the political perspective and ideological perspective. So you look at that, that's where the policies are made. They're not made in isolation. They're not made because the policy is a great idea. The policies are made by, it's like a sausage making factory. The process is not very good, but the end product is good.
So when you started out in your surgical career, when you say you we're good at rescue medicine, you really lived rescue medicine as a trauma surgeon then?
Absolutely. And I thought that was great.
I'm sorry, were you in physician leadership before you went to Pemba, or was Pemba what propelled you into assuming leadership positions?
No, I was in a leadership position, but only in the Department of Surgery, right? I was not in a leadership position in the hospital or across the departments. Then across the hospitals and across the systems. So it kind of, Pemba moved me through all those things, So I just came in there. I was just a young physician leader, trying to manage a department of surgery, in a hospital system, which is the 500-bed hospital with a trauma center, a teaching hospital, but that's it. It's
a lot of physicians see moving from physician leadership positions such as chief quality officer, chief medical officer, chief safety officer into more of the operational or executive sides as a real barrier. You have been the CEO of two very, very large healthcare systems, Cook County and New York City Health and Hospitals. How did you position yourself to transition into those roles?
I think the first thing they do is the doctors or physicians, as a rule, are very reluctant to learn about other things. For example, my first job was as a chief medical officer. Then I wanted to move into chief operating officer. So I spent 1 year taking a special course in Harvard of everything about operations. I understood how to do group purchasing. How do you order and procurement? How does the air conditioner work? How does the heating system works in there? How does he manage my dietary system, food procurement and management within the hospital system, right? How do I create a flood emergency plan for the hospital? All those things, which are the operational issues, you need to kind of know about it. Otherwise, what happened was when I was a chief medical officer, people used to say, okay, they'll come to you for some medical opinion, and you are in the team, but you are not playing a big role. They'll say, okay, how are the doctors doing with it? Okay, you make sure the doctors are okay with what they're doing. And my job is to go and sell it to doctors. Okay, that's what we're doing. But I'm not a decision maker. The chief operating officer making decision on the chief financial officer making decision how much of money I'm going to give you, right? So I was not, even though I kind of persuaded myself to think I'm great to see you as chief medical officer, my role was kind of not a big decision maker in the hospital system, at least. So I learned more and more about operations. So I need to get a street credibility. I need to be, the people in the administration, non-doctors, think, okay, this is not one of the doctors we put in the administrative role just because we want to show everybody that we have doctors on our C-suite. But it's more about, do my opinions and my advice count? To do that, you need to understand the day-to-day management operations. So, that means that you need to understand how the medications are procured. How do you want to do that? What happens with union contracts? About HR regulations, about what are the HR regulations we can do? What does it mean? So all those things, right? Hire and fire. How do you do that? How do you create a balance sheet? How do you manage things? All those things need to be gained by that. So I worked on that nearly for 3 years in taking various courses on operational issues so that my next step was chief operating officer. So I was able to convince people, okay, I know medicine, I know quality, I know safety. I also know operations. I know how to set up things. I know how to set up procure something. I know how to hire people. I know how to, mobilize people if I want to do that. So all those stuff, I understand what happens if my air conditioning system blows up tomorrow. I know how to get it done. Right? Not me personally, but I know how to mobilize people to get the things done. So that is what the big barrier you need to cross.
Okay.
So running the hospital is fine. Everybody thinks the entire hospital is okay. We just run it. Doctors giving care to the patient is a hospital. In a way, you're right. Doctors and patients are the most important aspect of it. But to provide the doctor to provide care to the patient, there has to be a system around you, making sure everything works. The telephone works, the air conditioner works, the food works. The patients show up, the parking lot is filled. Right, everything has got to be worked around you. Right, and I don't think the doctors understand the operational magnitude which makes the system work, so that you can provide care to the patient.
So how long were you you transitioned from, it sounds like, a CMO role into a COO role. How long did you remain in the COO position before you applied for the CEO roles?
About 4 years.
4 years, okay.
Yeah.
And was that in the same institution, or did you move from institution?
No, I went to the system, because the COO role, initially I was COO of a hospital. I was there for about 2 years. Then I wanted to learn more about, being a COO of the hospital is different from COO of a system, which is much bigger, right? So then I moved into COO of a system, public system in New York City Health and Hospitals. There I became chief operating officer and chief medical officer. I had both roles at the same time. So basically, then I moved on. I remained in the system role for about 4 years. Then I became a system CEO. As part of it. Then I moved on to system CEO level. So I think the progression is CMO, hospital COO, system COO, and system CMO COO, then CEO. Because a lot of times the doctors go from CMO to CEO, but in my opinion, again, it's my opinion, a lot of CEOs, doctors who have done a great job, but to a great extent they depend on a very good operational person next to you. And if you don't have the right operational person, your role as CEO will be a problem, because you don't know whether what he's telling you is right or wrong. You have no clue. So you need to have that knowledge. You need to do that. So that is one of the areas where we have to really, as we train physician leadership, we train them mostly on all the doctor-related stuff, but we also have to teach them more about, what we call as, purchasing, contracting, human resources, right, management systems, right? All those things need to be taken into consideration. Capital, how do you apply for capital dollars? How to develop capital dollars? What need to be done? So all those things are so important.
That's great. Well, that's great advice for people who are looking to sort of move out of the more traditional physician leadership roles in organizations. I really appreciate you sharing that with us. We've kind of reached the end of our time, and I always like to close by offering you one last opportunity to give the listeners, the physicians who are listening to this podcast, any additional advice or particular lessons that you've learned in your career as you've gone through these stages.
More important than that, let me say, the things I wanted to do I could not achieve, because my healthcare career is kind of at the fag end of my healthcare career, but the people who are coming behind me, the one thing I really wanted to achieve is that we need to change the status quo in healthcare. I'm not talking about the operational management healthcare, right? That simply means the healthcare needs a lot of entrepreneurship and innovation. The doctors are not necessarily good entrepreneurs. They don't know how to manage a new idea or new management. They have great ideas, but they don't know how to bring it to fruition. The ideas could be a new gadget, or it could be even be a new process, or a new procedure, or new structure, new governance, whatever it is, right? So all those things need to be there. So we need to have doctors always thinking an opportunity to challenge the status quo and say, hey, how can we make it better? Because the industries only get better when there is a innovation, when they change the way they think and they change the way they manage. Example is banking industry. How much it changed, from viewing tellers, we go to the bank and stand on the line to cash a check to, putting the things in there. They moved away tremendously from the management system. Right? It is all given to them in their hand at their convenience of doing that. How can we make the healthcare that convenient? We talked about it initially. I'm going to come to complete. Is healthcare convenient? How can we make it more convenient for people to access, to understand the knowledge and the management, how to take care of themselves better? All those things have to be there. They all have to come with new innovation, new entrepreneurship, ability to manage new ideas into a new product or a new procedure. I could not do it. Now, I try to teach that more, but I was not able to do that. I was not having any entrepreneurship in my life, because I came to the realization very late in my career. By the time I said, hey, I need to develop some entrepreneurial skill, I'm running out of the clock. So I'm running out of the clock. So I just wanted to make sure that's something I really want in organizations, and especially teaching, like Pemba, we need to really teach people how to be, entrepreneur. That simply means doctors have great ideas, but how do you bring their idea to fruition? How to sell their idea? How to capitalize on it? How to commercialize it? And that would be a great idea to do that. And unfortunately, we have to really figure out a way of doing that. And even teach medical students. We teach them historical medicine, but we need to teach them future medicine. The future medicine is probably more important than teaching historical medicine.
Well, thank you, Ram. This has been great, and I appreciate those last comments. Innovation and execution and implementation. With any one of those three elements, if we're implementing the wrong idea, or we have a great innovative idea, but then it never gets implemented, it's not helping our healthcare organizations and ultimately not helping our country become healthier, which I think is what you've spent your entire career trying to achieve. So thank you very much for sharing that.
Well, thank you very much for the opportunity. It's always a pleasure. Again, I want to tell you, I owe it all to Pemba, because without Pemba, I would not be anywhere, where I am today. And more, not importantly about the jobs, about the positions, that's all immaterial to me. The knowledge I gained and the vision I developed, and my focus has so much become broader, because of Pemba. That's more important to me than, the jobs and the positions, they came and gone, but that's not important. But I was able to think differently and look at problems much more in a different way because of Pemba and the teachers of Pemba. So I'm indebted to them for that, and I will do anything I could possibly do to promote and help on the future people coming from Pemba. Thank you.
Yes, I'm sorry. It's been a pleasure having you on the show, and hopefully this won't be the last time we have you on the show. I hope that we can chat again, because you've got such a tremendous amount of experience and knowledge to share.
Thank you. Good to see you. Have a great day. Bye.
Good to see you as well. Well, I hope you enjoyed this episode of Pemba On Demand, Physician Leaders Making a Difference. I was pleased with the topics we discussed tonight that actually went well beyond quality in healthcare, touching on healthcare policy, the necessity of physician leadership in healthcare, and hearing about Dr. Raju's career and his excellent recommendations and advice for physicians who are interested in COO and CEO positions within a healthcare organization. That wraps up our show for today. Thank you very much for joining and listening to the podcast. If you have any comments or questions regarding this episode, please feel free to add them in the comment section on our website, tiny.utk.edu/POD podcast. We love hearing from you and are happy to answer any questions you may have. I will add a link to the website below. Please also don't forget to subscribe to the podcast by clicking the subscribe button. Add Pemba On Demand to your podcast library today. I would also appreciate it if you could leave a review of the podcast on your podcast player. Share the podcast with your friends and colleagues also. Please take good care of yourselves, and as always, good luck with your future.